Good afternoon, and thanks for joining me today. I'm Andrew Arndt, Director of Thoracic Surgery for the West Region of Northwestern Medicine. We're filming live today from LivingWell DuPage, next to the Northwestern Medicine Warrenville Cancer Center and Proton Center. I'll be speaking today about what to expect when you're expecting lung surgery. The goal of today's talk is to really cover the basic course that you can expect when you're referred to a thoracic surgeon for a diagnosis of lung cancer. If you have any questions during the talk, please post them in the comments section, and I'll be happy to address them as time allows after. Lung cancer remains one of the most common cancer diagnoses and overwhelmingly the most common cause of cancer-related death in the U.S. Naturally, its diagnosis generates a lot of concern and worry, but thankfully, with improved screening efforts and improved treatments, we're diagnosing patients at earlier and earlier stages, and we're creating better tolerated, more effective therapies to treat lung cancer. When you receive a lung cancer diagnosis and are referred to a thoracic surgeon for lung cancer surgery, one thing to really take heart in is the fact that this generally means your cancer is at an early stage and hopefully one that can be cured. And so, of course, while a lung cancer diagnosis is very shocking and very saddening frequently, the fact that you're getting to a thoracic surgeon generally means that it was caught early and hopefully can be treated and cured. Lung cancer treatment, as with other cancers, varies according to stage, and generally it's the early stages that is most benefited by cancer surgery. In terms of some of the most common questions we get in the office and from patients and families surrounding lung cancer surgery and the diagnosis is, what surgical options are available to me? Is this something for which I have hope? Is this something from which I'll be able to recover? Or is this something that I'll really struggle with? In terms of the surgeries available, we aim to do most of ours minimally invasively. The old-fashioned and the original techniques were all, of course, open surgery, with a large cut on the side, spreading ribs open. These were effective at removing lung tissue and lung cancer, but definitely challenging to recover from, sometimes with week or two long stays in the hospital, several months of pain, several months before getting back to normal everyday activities and getting back to work and things like that. In the last few decades, there's been a turn toward minimally invasive surgery. This has occurred both in the abdomen with laparoscopic surgery and also shortly thereafter in the chest with thoracoscopic surgery. The initial minimally invasive chest surgery was called VATS, or video-assisted thoracoscopic surgery, which is working with a video camera in between the rib spaces without spreading ribs, and then inserting small instruments also in between rib spaces to free up lung tissue and remove it. The newer version of this essentially is robotic surgery, where it's a similar principle of working with a video camera in between ribs, but one of the things that the robot offers is a little finer movement of the instruments, more range of motion for the instruments, and as on the surgeon side of things, it gives a better camera view, an up-close, very magnified camera view, and really precise movements. And so both of these minimally invasive techniques are what we favor nowadays rather than open surgery. The other question to think about when thinking what sort of lung surgery is available to me or will I be having is the amount of lung to be removed. Classically, when we're dealing with a lung cancer, we take out an entire lobe of the lung. There are 5 lobes, 3 on the right, 2 on the left. And the most beneficial way to take out a lung cancer has historically been to remove one of the lobes. Reason being is that it's kind of choking that off by the root. Each lobe has its own airway, its own artery branches, and its own vein branches that go to it. And by taking out the whole lobe, that helps to prevent recurrence. More and more we're studying whether we can take out segments of the lung, a segment being an even smaller portion of the lobe, but again, each with its own airway, artery, and vein going to it to kind of choke it off at the root, but spare some lung tissue and not have to take out as much. And there's certainly encouraging data that for cancers less than 2 centimeters in size, this is an appropriate treatment. Other types of lung surgery we can do are wedge resections, which is trimming out just the nodule or the cancer itself. This is something less favored because we do know that it has a higher recurrence rate, but it's something that we sometimes do in patients who otherwise couldn't handle having more lung taken out, or who have had radiation treatment before and just need that individual spot taken out rather than a whole lobe of the lung. And then in rare cases, but certainly doable, is to take out an entire lung, the right or left lung, called a pneumonectomy, or to take out multiple lobes on the same side, for example, the middle and lower lobe on the right side, which would be called a bilobectomy. So there are many options that range really based on size of the cancer, location of the cancer, and fitness for removing some lung. In terms of preparing for lung surgery, the two main questions that we as surgeons are looking at are, one, what is the appropriate type of surgery to be done, or is surgery appropriate at all to be done? And two, if surgery is warranted, is the patient fit for it? In terms of looking at whether or not surgery is the appropriate procedure or treatment for lung cancer versus chemotherapy or radiation, we start by staging the cancer and doing what's called clinical staging. And this is using CAT scan, PET scan, brain MRI, and other modalities like endobronchial ultrasound to help us get a sense, before we go in there and do any cutting, of how advanced is this? What's the size? Are there any lymph nodes involved? Are there any metastases or sites of spread to other organs? And so, at a bare minimum, every patient we see will get a chest CAT scan. Almost everyone will have a PET scan. And then depending on size and location, some patients will get a brain MRI and an endobronchial ultrasound, which is a test to place an ultrasound probe into the airway and look for lymph nodes that live in the center of the chest. If these all show that the cancer looks like a stage 1 or a stage 2, then surgery is the most appropriate upfront treatment. The next thing we really look at is, can a patient tolerate surgery? We know that lung cancer increases with age, and we know that also with age, our breathing capacity gets lower and lower. And so one of the things that we really want to check is, can the lungs handle surgery? So in addition to getting routine blood work to check for blood counts and clotting factors and things like that, one of the things that all of our patients get is called PFTs, or pulmonary function tests. And this is a set of tests that judges the lungs' capacity. It helps us get a baseline of how breathing is, and it helps us see, if we have to take out a proportion of the lung, what will the leftover function be like? Will the patient need home oxygen? Is the patient at higher risk for a pneumonia or needing to stay on the ventilator or something like that? And so it gives us a measure of really the risk to the lung of doing lung surgery. The other organ system we really look closely at is the cardiac system. We know that the heart and lungs work very closely together, and so we want to make sure that the heart can tolerate lung surgery as well. And so we often will always get an EKG, or an electrocardiogram, but we often also will get an echocardiogram or a cardiac stress test to really prove that the heart and lungs that are working so intimately together will both tolerate the surgery. Other workup is really dictated by the primary care physician, whose involvement we pretty much always solicit to make sure that the patient can handle surgery and that there are no misgivings about what medications to take or different organ systems that are potentially at risk. From a patient's side, the best way to prepare for surgery is to really kind of keep up your normal level of activity. We want you to be walking around, staying active, being fit leading up to the day of surgery. We hand out what's called an incentive spirometer. It's a little breathing device where you inhale and try to elevate a disc. It's something that we really harp on after surgery, but it's also helpful before surgery. One, to get used to using it and to kind of set your own personal targets for how much inhalation you can do, how high you can raise that disc. And then after surgery, it gives a good measure of kind of what you potentially could shoot for. And then, of course, the other thing that's really great before surgery is to not smoke. Quitting smoking, especially a few weeks ahead of time, is really, really helpful for recovery. In terms of recovery, everybody's certainly a little bit different, but we kind of have a basic course that we hope for during and around the time of surgery. When you come in for lung surgery on the day of surgery, you arrive the morning of. Our hope is to do this, of course, minimally invasively, which usually takes about 2 to 3 hours, sometimes a little bit longer, depending on just anatomic factors of how the lung is arranged, how the blood vessels are arranged, and things like that. But we aim for 3 hours or less of surgery. Surgery is done under general anesthesia, of course. But at the end of the case, we always plan to get the breathing tube out, get you over to the regular recovery room, regular recovery floor. We don't anticipate an ICU stay. Pretty much immediately after surgery, when you're on the floor, we want you walking around and out of bed. Being even up to the chair is beneficial over staying in bed. And so we want to get you back to normal baseline activity pretty quickly. The typical length of stay after a lung surgery, particularly a lobectomy, which is kind of the classic operation we do for a lung cancer, is about 2 to 3 days. And the big factor that leads to this is that we leave in a drain called a chest tube. The chest tube helps to drain out blood and fluid from the chest space. And what it also does, which is pretty unique to lung surgery, is drain out air. After lung surgery, the lung that's left behind can leak out air from having the lung that's taken out separated from it. And we want to make sure that this air is evacuated rather than building up in the chest cavity. And over a day or 2 or 3, the lung that's left behind will seal up those little air holes from any abrasion or from needing to separate the lobes of the lung. And once we're able to get that tube out, pain gets a lot better, mobility is a lot easier, and you're typically ready to go home. Once you're home, recovery, of course, also varies from person to person, but typically by about 2 to 3 weeks out, we expect you to be most of the way back to normal in terms of things like strength, stamina, energy level, breathing, pain control. And so we expect a pretty accelerated recovery pretty quickly. Getting back to 100% is highly variable. Some patients get there at the 2-week mark, some patients take 12 weeks or longer. But typically, most patients feel pretty good by 2 or 3 weeks after surgery and are getting back to most everyday activities and getting back to work, provided it's not particularly physically strenuous. One question that we always receive is, when can I fly? Whether that's flying home, since if you've come here for surgery, or just want to take a vacation to get away from it all afterwards. If you read online, there are highly variable accounts of when you can fly, but really most typically you can fly once you're cleared in an office visit a week or 2 after surgery. We check an x-ray, and if your lung looks nicely expanded and there's no residual air pockets or fluid in there, we're typically able to allow you to fly, which is really nice. In terms of kind of the long-term side effects, people always wonder, will I have chronic pain from this? Will my breathing be permanently impacted by this? In terms of pain, that will go away. Early on, we send you with pain medicine. We also do a lot of numbing of the chest wall, local anesthetic during the surgery to help prevent high pain early on. And then in terms of breathing, a lot of that is patient to patient, but provided we did the appropriate workup ahead of time in terms of pulmonary function tests and things like that, most patients really feel minimal day-to-day impact with breathing. Certainly, if you were to go for a really long walk or a long run or something like that, go on a ski vacation to a high altitude, that could be impacted in the short term. But we definitely expect that breathing, especially for day-to-day activity, is pretty much back to normal. And then finally, one of the big questions we always get is, will I need other treatment? Will I need chemotherapy? Will I need radiation with this? Sometimes these treatments all work hand in hand. Sometimes patients receive all 3, surgery, chemo, and radiation, or sometimes 2 of the 3. When we do surgery for an early stage lung cancer, the things we really look at after surgery to determine whether other treatment is needed is the final pathology. And so we send off the tumor or the lung specimen to the pathologist, and we also take out lymph nodes that live in the area. Lymph nodes help to filter blood from infection, but they're also avenues that cancer can travel. And so we have the pathology team check for the size of the tumor, whether or not it was completely removed, whether or not it had invasion of any structures nearby, and then we check lymph node status as well. And generally speaking, chemotherapy is recommended, or we refer you to medical oncology if lymph nodes are involved, or if the tumor is greater than 4 centimeters in diameter. And then in terms of radiation, typically radiation is reserved for if any of the tumor was left behind. For example, if it was invading a structure that couldn't come out, like the heart. Or there are situations where certain lymph nodes are positive, and that's a reason to do radiation. And so there's certainly treatment possibilities after, and those are all dependent on final pathology. At this point, I'm certainly open to taking any questions that we have.
I do have a few that have come in beforehand.
So okay.
We'll start with those. Okay, this is the burning question. Anything on the horizon with lung cancer surgery? And are there any new developments that you could talk about today?
I think a few of the neat developments as far as lung cancer surgery or treatment of early stage lung cancer, one great development has been the advent of lung cancer screening, which isn't surgery itself, but has really helped to get more and more patients to surgery. Lung cancer historically has been diagnosed at stage 3 or 4, the more advanced stages, when surgery is typically not really available and when cure is not necessarily possible. And so lung cancer screening with low-dose CAT scan has taken an at-risk population, patients who have a smoking history and who are, initially it was ages 55 to 75, but we're trying to expand that. But it's trying to look at, do these patients have cancer before they know they have cancer in the form of cough or chest wall pain or shortness of breath or coughing up blood? And this is really starting to tilt the detection of lung cancer to stages 1 and 2 rather than 3 and 4. And so that's really been helpful in the treatment of lung cancer, detecting it earlier and earlier. From the surgery standpoint itself, I think that it'll continue to get more and more minimally invasive. The robot platform that we use now has the potential to have smaller and smaller instruments with less cutting, less disturbance of the body's tissues. There are single site robots now where through one incision the robot arms kind of go in and then can splay out and offer the same level of dissection and the same level of precision and the same camera view through a single incision. And I think one of the things that might not be ready for prime time quite yet, but is a little bit of artificial intelligence, if you will, with the robot, in that the robot has the ability to detect tissue thickness and give warnings to the surgeon of, this is a blood vessel rather than soft tissue that you would otherwise just cauterize or cut through. And so I think some feedback mechanisms as a safety measure will really kind of help facilitate surgery, help the speed of surgery by anticipating where the structures we need to be looking at are found. But I definitely think that surgery will continue to get faster with smaller incisions and more well tolerated. The other thing too is, as I mentioned a little bit earlier, is looking at, can we take out less and less lung but still provide the same degree of cancer coverage? The first lung cancer surgery was an entire pneumonectomy, taking out the whole lung on one side, and then decades later, it was looked at whether or not taking out just a single lobe would offer the same sort of outcome. And now we're really asking the question of, can we take out less lung and still provide the same oncologic outcome, not shortcut anything. And I think those studies will continue to push the boundaries too of what we can do and help get patients back to really full activity with minimal impact on breathing and activity.
So, another question has come in from Jane.
Okay.
She's asking, I'd like to ask if respiratory therapy can help to regain lung capacity after a lobectomy.
Yes, Jane asks the question of whether respiratory therapy can help regain lung function. This is a great question and a hot topic really at the moment. One of the things that is being looked at is whether respiratory therapy before surgery is beneficial. Some of those studies are struggling to accrue patients, as typically once a cancer is diagnosed, we don't really like to delay the treatment for it, whether that's surgery or something else. And so before surgery remains to be seen, but certainly respiratory therapy after surgery can really be beneficial. Many of our patients won't need it based on pulmonary function testing and how they're doing just post-operatively in the hospital. But for many patients, going to respiratory therapy or pulmonary rehab is really helpful at minimizing the loss of lung function. Thankfully, the lung that we leave behind generally has capacity to inflate a little bit more. And so if we take out the right upper lobe of the lung, the middle and lower lobes on that side can expand a little bit. Even the left lung will expand a little bit and kind of shift the heart and trachea and esophagus over. And so while the lung itself doesn't regenerate, it certainly has capacity to account for some volume loss. And so in a surgery where we may take out 15% of lung tissue by volume, our hope is that in the long run, you're not losing 15% of lung function, but that with pulmonary rehab, respiratory therapy, and the body's kind of natural defenses and mechanisms, maybe you'll only lose 5% of your lung function. But definitely a great question.
One more, unless someone else comes in the comment section, but question is if a patient should ask their doctor about robotic surgery as an option. Is that something that a patient should come to the doctor about, or should the doctor?
So the question is about whether a patient should ask about robotic surgery. I think that's a great question. The studies are pretty well borne out that minimally invasive surgery for thoracic surgery or for lung cancer is better than open surgery. And by better, I mean in terms of recovery, length of stay in the hospital, time to get back to work, time to get back to regular everyday activities, time to get back to sports and gym class and you name it. And so minimally invasive surgery is definitely key. Asking about the robot, I think really is not just a question of is the robot appropriate, but I think it's also asking a question of does the hospital have the latest technology, the latest minimally invasive resources. And so while not every thoracic surgeon is necessarily using the robot, I think that question brings up should I have this done minimally invasively? What does that look like? And so I think it's really, really important to know about that. There are some surgeries that we do with VATS or video-assisted thoracoscopic surgery, and those are patient-to-patient discussions, so not every single case we do is with the robot, but we essentially intend to do every case minimally invasively with just a few small exceptions. And so I definitely think that an educated patient is a great patient. It's great to bring up something, even if you've seen it on a billboard or a commercial. There's marketing for a reason, and generally those technologies are here to stay. And so I think asking about robot surgery is certainly beneficial. And more places are doing minimally invasive surgery, which is really, really the key. And it's especially nice that studies are showing that these minimally invasive approaches are not having worse outcomes from a cancer standpoint. That's always the big concern, is kind of cutting down on access, cutting down on the ability to cure or treat a cancer, and we're finding that that's not the case, that doing surgery with the robot with minimal access is still getting the same outcomes. and in many cases better, actually, with just the visualization angles from the robot camera and things like that. So sorry, long-winded response, but definitely worthwhile bringing up the robot. It may not be the platform to use for every single case, but it's certainly a growing technology that really offers a lot of benefit.
That is it.
I guess that's all the questions we've had. Well, thank you so much for tuning in, and thank you for giving me the opportunity to talk here.
Actually, wait, I have one more
Oh, wait,
question.
Yes, one more question has come in.
Can a complete left pneumonectomy be done robotically?
Yeah, that's a fantastic question. So the question is whether a left pneumonectomy can be done robotically. I will say it's probably not being done with great frequency at any center robotically, but the short answer is yes. On principle, it's not terribly different from doing a lobectomy robotically. It's just more lung coming out. The challenges are that a pneumonectomy takes the blood vessels as close as possible to the heart, and so there's certainly less wiggle room or less recovery room if those blood vessels, which are extremely fragile, tear or start bleeding. And so I think that's been probably one of the concerns of places being a little slower to adopt it, just that conventionally it's nice being prepared, having hands in there if something goes awry during a pneumonectomy. The other challenge we face is maybe a more pragmatic one. It's that once the lung is detached, for any lung surgery that we do, we basically put it in a little indestructible plastic bag and pull it out through one of the incisions. Now, for a lobe of the lung, we could typically get that out through an incision that's maybe 1.5 inches or 2 incisions. The lung is pretty squishy and can slide through. Taking out the entire lung or doing a pneumonectomy is that much more volume, and so we tend to need to open up an incision a fair bit larger. And so that was kind of one of the headaches early on of trying robotic pneumonectomies, that it was one thing to detach the pulmonary artery, the pulmonary veins, and the bronchus to that lung, but then to actually get the lung out of the body required a fairly large incision. And so we're finding different ways to kind of work out that problem in terms of what are the best rib spaces that we could go through, minimizing pain afterwards and things like that. But short answer is yes, a pneumonectomy can be done robotically. It's certainly not an everyday thing, but no, there's no real reason that it can't be done.
I think, let me see if there's anything else coming in. No, it doesn't look like it, so yes, thank you.
All right, well thank you so much for having me. I'm very thrilled to be here at the new LivingWell Cancer Center in Warrenville, and look forward to being back.